So, hello everybody, good evening. Welcome to our webinar series with the newest broadcast. This is about artificial intelligence in practice. It's part of the Masterclass series in collaboration and in a very, really good and long-standing scientific cooperation with Bayer. Today, we have MEREL HUISMAN. Dr. HUISMAN is a renowned cardiothoracic radiologist and fellow in musculoskeletal radiology, but I think most of you know her because of her engagement with artificial intelligence and her efforts in both academic and clinical grounds to promote AI and to find and suggest new implementations that are in line with responsible AI that will be really assistant for the radiologist. She is also clinical epidemiologist by training, and this is very important because it has aspects that are related to AI. And today, MEREL will talk to us about this AI implementation journey. My co-moderator is Pinar Gilmans. She's also very well known from if you have participated in EuSoMII conferences and seminars, or if you have attended previous webinars in this series. So thank you both for joining, and the floor is yours, MEREL.
Thanks so much, Satirius, for this kind introduction, and thank you all for joining this webinar. The title of my webinar is the implementation of AI software in medical imaging still lagging? An analysis in emergency radiology. This webinar is based on a talk I gave on the ACER annual meeting. So that's the European Society of Emergency Radiologists in Rome last September. These are my disclosures. So currently, radiologists and end users of possible AI applications may feel a little bit like this. When they look at the AI landscape, they see popping up many applications, sometimes facing the same, solving the same clinical problem. And they kind of feel overwhelmed and they don't know which one to trust, which one to buy, which one will benefit their practice, and which one is robust. And this is a little bit, I found this picture quite fitting for where we are now in the development of artificial intelligence in medical imaging. And in this talk, I'll have I did a little SWOT analysis for you guys based on the currently available literature to make everybody a bit more structured and possibly less confused if you are. So the question is the implementation of AI software still lagging? In a minute, we will see why it might be lagging. I will talk mainly about commercially available applications. This will be about the content of the application and not necessarily the vendors. I will say something about the maturity level of the several applications. And as said, I have done a little SWOT analysis so that we all have, including me, a little bit more overview. So I think you're all familiar with this hype cycle. This is every year Gartner makes a hype cycle for several technologies, including AI. And in the past years, we were at the peak of inflated expectations. And as you can see now, deep learning, which is more or less what we're talking about when we talk about AI, is actually in the trough of disillusionment. So actually, we can say that implementation is still lagging. And Gartner predicts that in 2 to 5 years, we will reach the plateau of productivity. And actually, it is also known that the human brain is not capable of like seeing changes that move very slowly. So actually, I think we will reach the plateau of productivity earlier than we than we realize. But we have been overestimated the performance as well. So that is actually why the implementation feels like it's lagging, but actually there's a lot happening in the background we are just not so aware of. In 2020, the ACR Data Science Institute published a survey. This is mainly US based, but there in this survey, in a large group of radiologists, they saw that 30% of the US practices already is using AI and a quarter is planning on using AI. So chances are, if you're not using it, you will be soon. And I think Europe is just a little bit behind the US. This is also because of the reimbursement that sometimes does happen already in US and not here. But what we can say is that the market is maturing. Over the past 2 years, I saw, when you look at conferences and also literature and also discussion with peers, people are actually using applications, be it a pilot or some products bought or evaluated. And this was not the case, let's say 3 years ago. So the market is really maturing. When we look at market penetration is a metric where you would have the proportion of people that use an application versus the potential users. So that would be all radiologists or all technicians, or depending on how you define the market, but that's 2% and that is quite low. Let's say iPhone, I don't know, but it has like maybe 90% or 80%. There's also Android users, of course. Well, just saying. What we also see in this paper is that the in-house developed products, so in the academic, are popular. And this might say that sometimes the commercially available products are either expensive or do not suit a local problem. So we see also a rise of in-house developed products. I like to, when thinking about AI and also reading papers, I like to see AI as a data-driven medical device. Right now we call it AI or deep learning. Later it might be something else, quantum computing, I don't know. But what I do know as a doctor, that it's all a tool, and I have to judge that tool according to other, according to rules I use to judge other medical devices. For example, something a surgeon uses or a contrast agent we use as radiologists. So it has to have a benefit and it should not harm a patient. I think when we look at the market and development now, augmented intelligence is a nice term, not coined by me, but I think it's good to use because we are far from autonomous systems. This is a very nice overview by Mohammed Rezazadeh, and this is useful because here they looked at all the available applications and they made a subdivision according to target organ. And we see that it's a lot of brain still, the breast, lung, cardiovascular, chest, and not so much the more complicated organs, let's say the glands. There is actually a rise of abdomen and glands applications such as prostate. But as of now, we see the most mature products we see in those end organs, and those happen to be quite common, the brain and also the lungs. Those clinical questions arise a lot in emergency setting. So that's why I thought it would be useful to look at the emergency applications that are currently available, because potentially it can have a large impact on the emergency setting and also on the workflow in the ER. Another useful subdivision I like to make when thinking about AI applications is where it comes in the radiology workflow. If this is the radiologist here in the middle, let's get my laser pointer, yeah. Here in the middle, then there's some processes before the radiologist. For example, patient scheduling, modality selection, triage. So how urgent is the study? This is of course important for emergency. protocol selection, contrast agent reduction, automatic quality control and rescan, reconstruction, image processing. Those are all potential AI applications, potential tools that can help us for these use cases. Then we look at decision making. So this is actually the work we do, the interpretation as a radiologist of the study. And we see that most of the tools that are currently available actually fall into this category. So they replace or aid the human. And then downstream, that would be when the report leaves the risk system and comes in the patient information system in the form of a report, or we call the clinician, or we teach a resident. All those things would be downstream. And then you have also like billing and more like, let's say, back-end applications. It's good to realize that according to the MDR, that's currently prevailing regulation in the medical device regulation in Europe, upstream and downstream applications are lower risk, whereas always when patient decisions come into play, it is high risk, of course. And this is good to realize when you're looking at a tool, is it a lower risk or is it high risk? And also if you're developing tools, of course. Sorry. So an overview of applications can be found, that is for the EU at least, on the Grand Challenge platform, the website AI for Radiology, made by Kiki van Leeuwen. She is from my center Radboud UMC. This is actually very useful. And per application, you can also search per subspecialty, modality, CE marked or not. There will be technical specifications, data characteristics of the intended population, but also where it was developed on, market presence. So when did it come out on the market, the pricing model, and also some evidence is listed there. So the papers. So I made an overview for you, a summary of the applications that are related to the emergency department. And one that I think you all know is the acute brain CT. So there are, for example, at least 13 vendors targeting the suspected LVO, so large vessel occlusion. And most of them are targeting detection in the anterior circulation and in proximal stop. So for example, here you see an M1 occlusion. And there's also some products for hemorrhage detection on a non-contrast CT scan of the brain, such as this one. And actually in clinical practice, you see that the hemorrhage detection tool is used more frequently. And there's also has been some experience with LVO detection tools. I will talk a bit about later as well. There is some pulmonary embolism detection tools. There's at least 2 vendors I know of that have an application like this. And for example, here we see a contrast enhanced CT scan of the lungs. In the here you see the pulmonary truncus filled with contrast to detect pulmonary embolisms, and you see here a large embolus. Well, of course, we wouldn't miss this as a radiologist, and I think in a clinical setting, it is very clear that this patient is under a lot of stress. So there will be a big clinical team around this patient, because there will be right heart failure and dyspnea, etc. So I don't know if there's a lot of added benefit of a detection tool for this. But where I do think there's a lot of benefit is when in the working list that are getting longer and longer with oncologic follow-up, and there you have the subclinical pulmonary embolism. So there you will get a notification, and then somebody has to take action. So yeah, it can also help as a second reader if you're reading a study on on-call follow-up, and you might not always look at the lungs for pulmonary embolisms, but the tool can help you here. Some lesser known applications are the detection of free intra-abdominal air, such as this one. There's one vendor doing this. And also this is a dissection detection tool. I personally do not have any experience with this, nor do I know people who use this, but apparently these applications are coming out as well. Then there's by at least one vendor, the C-spine fracture. So on CT, that is, of course, this is the standard of care currently. I don't know, I do not have experience with this, but I can imagine that I would like to take a look myself, as this is very delicate work and you don't want to miss anything. So I imagine that there's always a radiologist involved still. In our center, we do have some experience with LVO detection, and we did a preliminary evaluation. It has not been published yet, but I can tell you the following. We tested the tool, and the performance preclinically is about 85% sensitivity. So you can debate, I think, if that's good enough for a proximal occlusion. You would miss 15 out of 100 patients. I'm not sure that's acceptable, to be honest, if you would have it as a standalone tool, but we tested it locally on our data and the sensitivity dropped to 70%. And that's not acceptable, I think, for a diagnosis that has such high stakes as large vessel occlusion. So in summary, I think preclinical, it has like promising or good, depending on, I don't know if I would say good, but promising performance, and then you apply it in clinic and somehow you don't get the same results. And this is something we see a lot. And I think this is really where what's happening right now. People are evaluating and reporting on these local outcomes. So this has to do with external validity. So apart from adding quality, so diagnosing more LVOs or quicker, something that seems to be on the rise is the care coordination platforms. There are several vendors now, and also some get reimbursement in the US for a per case, where they apply this new, let's say, workflow. And in short, this is these tools are designed as such that without a radiologist looking at the images, the clinician, so in this case, the neurologist or the interventionologist, is notified that there's a pulmonary embolism or a proximal occlusion, and then they can reduce the time to needle. So in a world where time is brain, as we say, I think this can potentially be very useful. Mind you, though, the evidence behind these reimbursements, actually, and also behind these tools, are mostly retrospective analysis. So it has not been proven yet that patients actually have a better outcome. So I think that is something that needs to happen. Yeah, that needs to happen quite soon, or at least needs to happen until before there is general uptake of these tools. But it's a new way of working. That's what I wanted to say, that we didn't imagine before, but now it's on the rise. So not so much standalone, but just shortening the patient journey. Then there's fracture detection tools. There's at least 4 vendors doing this currently, and they work quite well. And you could imagine that either the confidence for the radiologist rises, and there has been also quite some evidence on this also retrospectively, but it works well. Accuracy is very good. And you can imagine that the end user either feels more confident if they have a large pile of work, or it could reduce the number of recalls if there's no radiologist involved at first and he will only look the next morning. You maybe can assume that the ER physician with the aid of AI has a better accuracy, and also that has been shown in the literature. Does it actually improve patient outcome in terms of better mobility, less pain, less visits, less outpatient visits? We don't know. So this is something that we should look into. Then there's chest X-ray abnormality detection. There's quite a number of tools detecting from a few abnormalities, such as TB, to a lot, 150 abnormalities in chest X-ray, and accuracy is good. Depending on your local practice, though, for example, we at Radboud EuSoMII do not have so many normal cases that for us it's worth it. You kind of have to see for every, let's say if you as a radiologist take 3 minutes to report an X-ray, there's a monetary value to that, and that should be higher than the costs of the software. So in our case it wasn't, but it could be if you have a remote practice with lots of normals, that it's very useful for you. So if we look at the strengths, I think for decision support tools, just so for image recognition tools, I think strengths at the moment are that accuracy is as good as a human or even better than a human. And this can potentially be really good. We just don't know where to use it best yet. When we look at weaknesses, there is a lot. I'm a bit over my time. Do I still have time?
Yes, we can finish.
Okay. I talk more than I should have. That's what happened if you don't have the audience, if you don't see the audience. So I think the weaknesses is that currently we have all single point solutions. Okay, there's a laser pointer that's not supposed to be there, but we have a lot of multiple point solutions currently, and no autonomous system. So you can imagine if you, for your practice to really make an impact, you have to buy a lot of tools that in the end is not cost effective, I think, having multiple point solution, and it's also not speeding up your workflow. We see a lot of companies partnering up now. The rise of the so-called the platforms like marketplaces, where you can have a selection of the tools that are useful for you. Sometimes they're sort of checked on accuracy, and sometimes they're not, depends on the marketplace. And another thing is that the claims the vendors of multiple point solutions make are rarely supported on really systematic evidence. And this is something that's really important, and you always need to keep in mind what type of studies are done and where can you find them and also read them. So we don't have an autonomous solution yet to really aid us in the growing body of work we're doing as radiologists. A very general problem, this is not new, but I still want to highlight it, is that yes, we see a lot that the AI tool outperforms the radiologist in theory. So on paper, just like what I said about the LVO detection tool we evaluated. But if you apply it in your practice, the performance might be something like this. This is the area under the ROC curve. So it does outperform radiologists on very small and obvious tasks in perfect preclinical conditions that it actually should be under every claim. Something else that actually is very related is that the survey of the ACR Data Science Institute I talked about earlier showed that if they asked the radiologist, does your tool perform consistently? the majority said no. So almost 95% said that the performance of their tool was inconsistent. And if they were asked for the reason, in more than a third, there was no reason. So there might be just, some random variation. It might, yeah, just like noise in a scan, let's say. So this is something inherent to the deep learning tools. Also, there's no I don't know option in your, the output will be binary or maybe a probability of your tool. And for example, this was a paper where they looked at bone age prediction in other inputs. So this is in the middle, we see a chest x-ray and we see flowers on the right side, but you still get a bone age for the flowers as well. So the a tool will not indicate that this is not a child's hand, which is of course a mistake a human would never make. So in that sense, AI is still stupid, as we sometimes say. The opportunities, I think a time savings. And for example, bone age, it will do it in a fraction of a second, whereas looking at the atlas still costs a lot of time. Even searching the atlas in your department, it might sound familiar to you, might take you quite a few minutes. And then we have the potential, AI gives us the potential to reshape care pathways. So efficiency might be higher. This still has to be proven though, but I think in theory it could mean a lot for us. AI never gets tired. So for remote areas or areas where there's a shortage of radiologists, it could come in very handy to have a fracture detection tool or a chest ray abnormality detection tool. And I think if you have AI working in the background, it can monitor your performance. For example, missed nodules. And you could have a weekly report, for example, and you could review your missed findings. And I think that could really increase your confidence when reporting and when you have to report fast, for example. When AI has got your back, you can work maybe faster. So the wins, big potential wins, I think in workflow support, I really hope that vendors will come out with an automatic protocoling tool or an automatic hanging tool rather than more perception aids. And I think this is really underestimated. The threats, the shiny object syndrome, it's new, but there's no real benefit. This is what we currently see a lot. Actually, it might cost you more money, more time, more people. So this is also a viable option, that it's not making it's not generating any wins, but just costing a lot more resources. And some people have the experience that when you always see a notification for a suspected finding, you get tired. I mean, we also on our iPhone, we sometimes disable notifications because it wears us out. So this also can happen with AI tools. Then currently radiology departments themselves pay for the tools, whereas the actual win might be for the clinician. For example, the fracture detection tool, the win might be for the orthopedic surgeon or trauma surgeon. So who should pay for it? That's not decided yet. Regulations concerning privacy, they're necessary. However, they're also rigid, sometimes unclear. So this definitely does not help implementation. And like I said, disappointing performance, inconsistent. The tools can perform inconsistently, are not robust, and external validity is not the same as the preclinical validity, the promises of the tool. And if you're not careful, if you're not monitor your performance over time, it may drift. That's called data set shift or performance drift of the tool. It may be due to a scanner updates or different technicians that your tool suddenly starts to perform really poorly. And this is something you have to monitor, just as you have to monitor your performance of your MR or CT systems. And last but not least, bias towards certain underrepresented or disadvantaged groups. data where the algorithm was trained on might not always include disadvantaged groups, and you have to be careful when actually those are present in your local population. Some solutions. I'm going to speed a little bit up now, I think. Education is key for everything, and multidisciplinary teams are also key, I think, for AI. And you have to actually solve an actual clinical problem you have. So the clinical pull is important instead of the technical push we used to have a lot. And you can ask the vendor for a pilot. Be aware though, pilots do cost you resources, money, time, or mental energy, but you should be able to get a pilot, and you need to evaluate also according to predefined goals in specific timings. Did you attain those goals or not? And what were the failure cases? Failure analysis is something I think is becoming very important. If the algorithm is not robust and it's failing sometimes, it's good to look at those failure cases, analyze them. What is the cause of the failure, and can you prevent it? This is all for patient safety. And I think the vendor should be able to help you with this. Do not forget the radiologist or the technician. For example, if your MRI scanner is really fast, this will demand a lot from the MR technicians. For example, they have to handle much more patients, for example, than they are trained to do. So do not forget to human in the loop, because I think this is really key to make it a success. Because in the end, it's the people that do the work. So to conclude, be informed, avoid shiny object syndrome. Not everything that is new is good. Collaborate with all the stakeholders and evaluate. And I think that's way we can shorten the implementation period and hopefully have benefit of AI. So you'll be able to rewatch this video. So here I have some key papers I still think are important. Even if you don't like to read a lot, these are really good reads, very easy to read as well. And that's it. That was what I had to say. So I'll
thank you very much. Merel, it was an excellent presentation again. We have a few questions. We're a little bit over time.
We are.
Yes. So let's start with the first. The first is actually more comment. From whatever has been presented so far, it looks like investors are burning their money by funding medical imaging AI. Do you have a comment on this first?
Okay. Oh, that's the
yeah. It was more a comment. So
a comment exactly. I was waiting for the question mark. Yeah, I can agree with that. Investors might be burning their money. That is because of the peak of inflated expectations. It looks so promising, of course, when you develop a tool that can replace quote unquote radiologists, but in practice, it's not the case yet. And yeah, they might be burning their money. I think many tools will cease to exist, and some unexpected tools will take huge steps forward. And I am expecting the workflow tools. So automatic protocoling, hanging, things that cost a radiologist a lot of work, but actually don't need a medical background or really analytic skills. Sometimes it's more like the clerical tasks.
Yeah.
And I think that could save us a lot of time and money, actually.
Yeah, I agree with you. I think time will show, obviously, when it all started with the nice graph that you showed, how it evolved in time. I mean, a lot of things changed as well. So time will show us in what will change and what will not. The second question is by Dominic Stosik. Great presentation. The hospital he's working at actually is negotiating with a tool developed that is detecting only pathology. So the radiologist would not be called at night several times to evaluate every image immediately. The report has to be written by a radiologist afterwards, though. So he says this company has a clause in their contract covering responsibility, but is there an actual regulation concerning responsibility? And you actually mentioned this at the end, like who ultimately is going to take the responsibility?
Now, I'm not a regulation expert, but accountability question has been there for a long time. And from what I have observed, most people say that it always will be the radiologist or the physician. So whether it be a pulmonologist or trauma surgeon, maybe in the future it might be also partially the vendor. But in the end, we are applying something to make a decision on a health outcome, and we are responsible for that as doctors. So I think it will be us. But I don't know.
Yeah, I think we should definitely be involved. But indeed, it's a teamwork. I guess it would be nice to, even the people who are within the department working or supporting tools to get involved within clinics, that we should be part of it or be involved with it to think along. Third question is, what areas in radiology are missing AI tools?
Okay, yeah, that I know the answer to. It's one of my favorite questions. Well, like I explained to you, the upstream applications. So that would be automatic protocoling. Apparently, one study said that there's one FTE, one radiologist FTE spent on protocoling. And of course, that's personalized work sometimes, but especially in more regional hospitals, it's not that personalized. It's very standardized, actually. So that could be automated, hopefully. And then hangings, I personally spend a lot of time on making a good hanging. For those of you that don't know, hanging is putting the images in the right order for you to make a sensible analysis. And sometimes you have to open all prior studies just to see that it's not the correct body part, or, you know, this is not always very well organized, depending on your PAC system. So I think I would love a tool for this. Yes.
Even though it's in some exams, it's automated, and you still want to have other hangings.
Also, yeah, because depending on the classification, you need like longer go longer back in time. Let's say go further back in time. Or you need some detailed images, or even some scans from another body part where the lungs were partially also imaged, for example.
Yeah, thanks. This actually is related to the question I had. You showed a nice pie chart with the division of the tools that have, I guess, the most interest within the AI world. I have the same thing within the Erasmus Medical Center where I work. It's brain, then it's a lung embolism, and then it's also the cervical spine fractures. What is your vision in giving this great overview of how that pie is going to change? I mean, you also mentioned prostate a bit, but
yeah, so what we see now is more like the oncology applications. I think those are a bit more complex, as they involve more detailed segmentation, and sometimes also variations in positioning, like breathing artifacts or things like this. I'm not a body imager, by the way, but I think we're going to see more follow-up applications. At least that would be very useful. And there's like you said, there's, for example, prostate, but I think there's also some liver tools coming out. But this is not really my expertise. But from the literature, I know it's becoming more body oriented, the field of applications.
I guess also more disease specific, or you also have the tools within the prediction of the progression of the disease.
Like you have in neuro, for example.
Indeed.
Yeah, I think probably PNR means that, let's say, for neuro Alzheimer disease volumetry, so dementia, this is a high flying currently application.
Yeah, and the volumes, I mean, like the with the birth references in how
or yeah, on the
certain
multiple
volumes should be.
sclerosis volumetric. So
Yes.
these are really high flying and well validated, at least. So they have paved the way for the other, for stroke, so to come. I have two remarks. First is, before you mentioned the vetting process and how AI can be employed to do that. We are trialing that. I don't know there is any commercial package out there, but we have to customize something. And the outcome is very much dependent on the quality of the input. In other words, if the clinician or the referrer writes a quick and dirty referral, then the outcome is disastrous. And we need to educate the referrers to spend time to work on the clinical details. So in that case, the vetting process will choose the best for the patient. There are also the supporters of the personalized care and personalized radiology or imaging. They would definitely argue that this is not the way to move forward. But okay, this is open to debate or to, let's say, experiment, trialing.
No, I agree absolutely with that. In academic centers, I don't think automatic protocoling you're referring to, right? Or would be the way to go.
Yeah, so in my hospital, we have 600 referrals every day. So it is not only one person's work, it's two persons full-time work.
Yeah.
But still, a lot of things can go wrong. And it will, according to my understanding and to my experience, it will take years in order to lay back assured that the vetting process will be done by an AI. But the good thing is it will become possible because the volume is big of vetting. And if there is coordination of different centers, this will make it possible. And my last remark is I liked very much what you showed before, this care coordination platform. I find it a very nice term. And this is the beauty here in AI. Before something is really exhausted, or when it is still in the upslope of the hype cycle, the next opportunity starts and opens up for trialing.
Thank you.
So I have one last question, and it will be really the last question because we're really over time. So those AI applications which with quantitative results will survive, is that how the field is going, is evolving now?
Is this a question for me? Sorry, I'm not entirely.
Yes. So the ones that I guess the question is, what we see now, what you also explained, is that the ones with the good results, so a good AUC curve or an ROC curve, they are far ahead in getting implemented or getting people's attention, right?
I don't know, like, yeah, of course, if you have a bad performance, it's not gonna work at all. But I don't know if you have like a sensitivity of 98 versus 99, if it's really gonna make a difference. I think at least the tools that would get my attention is that perform in a robust way in all types of settings. And then I think
and the external validation.
Sorry?
Yeah. And the external validation, what you said. I mean, I guess that's the leading part of having next to a good performance is performing in general.
So if you mean the area under the ROC curve in all kinds of centers, then yes. But in order for us to gain some trust on AI. It should not have many failures, not shut down or give errors. And this also sometimes happens, just like with any computer program. And I think we still need to collect some evidence on this. And I think at some point you will hear from colleagues which ones are good or not. And there should be some type of rating system, obviously, but we in Radboud are working on this, but it's going to take a long time. And I mean, yeah, I think robust results, also user-friendly and not too expensive, I guess, because this is also important.
Yeah, I guess there are a lot of more than only the good performance to take into account.
And I don't know everything. This is just my personal impression of the field, and maybe some people have other smarter things to say as well. But this would be my idea. Yes.
Thank you very much, Merel, and thank you for the audience for being here with us again. It was a great start of the webinar series. Our second webinar will be on November 15th. Keep that in mind, presented by Eric Ronsard, and he was a past president, and he will be talking about how to select AI tools for clinical practice. So we're going to take it a step further in what we've learned today. Thank you, everybody, and have a great evening or morning wherever you are. See you next time.
Thanks so much. Bye-bye.
See you soon. Bye-bye.